Well, of course, the drugs that have made the big impact in this disease are the BTK inhibitors. And the question is, in a young patient's situation, do you actually need some of these new drugs in the frontline setting? Because the outcomes are pretty good, actually, if we use high-dose cytarabine and patients are off drugs and normal quality of life. And then when they relapse, because everybody relapses, then that's when we tend to introduce these novel therapies. There's a trial ongoing in Europe right now taking a high-dose cytarabine regimen, and there are 3 arms in the trial. One is the standard, which is the chemotherapy followed by the transplant with maintenance. Then there are 2 experimental arms, one incorporating ibrutinib into that algorithm, and then the third one drops the autograft. So if you incorporate ibrutinib frontline, do you need the autologous stem cell transplant at all? So that's a big study. It's going to take quite a few years to recruit, but it's going to challenge the sort of conventional paradigm, do you need the transplant? So that's something for the future. I think it's difficult right now in a young patient group to switch to anything other than the conventional chemotherapy. One of the things that I always say when I give talks about this disease is don't forget chemotherapy works. There's lots of excitement about new drugs, obviously, and the odd thing I think with mantle cell lymphoma is those new drugs, if we're thinking about the frontline setting, are going to be far more valuable, I think, for the older, frailer population, where chemotherapy really doesn't work very well, than in the younger population where it works really well. So don't forget chemotherapy, and be cautious in getting involved with new drugs early, particularly in patients with good prognosis disease, and that's usually the younger patients.